Rajiv Gandhi Government General Hospital, Chennai, postgraduate first year. My topic today is aneurysms caused by connective tissue abnormalities. Connective tissue diseases. Generally, connective tissue disease is a genetic disease in which the primary target is either the collagen or elastin assembly of the vessels, which leads to degeneration, loss of structural integrity, and consequently leading to aneurysm formation and vascular dissection and rupture of the blood vessel. Clustering of aneurysms in multiple affected family members may indicate some element of inheritance pattern. They are often greatly varying as they are varying in their levels of expression and penetrance, and also there is no defined genetic test is available to assist treatment. This is a table from Rutherford showing the structural elements of blood vessels. The blood vessels are made up of collagen and elastin. Type 1 collagen is contributing 20 to 40%, and type 3 collagen is contributing to 20 to 40%. These contribute the fibrillar network of the blood vessels. And elastin, which main function is elasticity of the blood vessels, is also approximately present up to 20 to 40%. Type 4 collagen is present less than 5% of the blood vessel, and it contributes, its function is maintaining the basal lamina. Type 5 and 6 collagens are less than 2%, function is unclear, and proteoglycans are less than 3%. They contribute to the resiliency of the blood vessels. These are the connective tissue disorders which we are going to discuss today. The heritable disorders of connective tissue have severe vascular manifestations, and these most commonly include Marfan syndrome, vascular type of Ehlers-Danlos syndrome, which is type 4, Loeys-Dietz syndrome, and familial thoracic aortic aneurysm and dissection. Coming to Marfan syndrome, the incidence of Marfan syndrome is 2 to 3 per 10,000 individuals. The lifespan of the individuals with Marfan syndrome was significantly shortened before the widespread use of the use and refinement of the aortic root surgeries. The cause of death was cardiovascular cause only, mostly due to aortic rupture, aortic dissection, or valvular disease. And in 90% of the cases, the mean age of death is at around 38 years old. Coming to the pathogenesis, Sakai et al. First identified fibrillin 1, which is the principal component of the extracellular matrix microfibril. This is present in all tissues with phenotypic manifestations of Marfan syndrome. Marfan syndrome locus is 15q21.1. It is an autosomal dominant condition. Coming to the microfibrils, these microfibrils are required to maintain normal elastic fibers during the postnatal life. If proper connections between the elastic fibers and the smooth muscle cells are not maintained, these matrix degrading enzymes such as matrix metalloproteinase type 2 and 9 may develop and will cause degeneration of the vessel wall. As the aortic valve wall homeostasis is disturbed, the inflammation as well as calcification and structural weakening of the elastic fibers will lead to aneurysm formation. The classical lesion of cystic medial necrosis will be seen in large arteries of individuals with Marfan syndrome. There will be dysregulated transforming growth factor beta activity. This dysregulated activity explains the clinical features of Marfan syndrome such as long bone overgrowth, muscle hypoplasia, and other craniofacial abnormalities. These are the key genetic problems in Marfan syndrome: excess transforming growth factor beta activation, excess transforming growth factor beta signaling, leading to the phenotypic consequences like aortic aneurysm, dural ectasia, emphysema, mitral valve prolapse, etc. Coming to the clinical features of the Marfan syndrome. Marfan syndrome is a multi-system disorder with manifestations primarily in the cardiovascular system, ocular system, as well as in the skeletal system. The cardiovascular manifestation is aortic root aneurysm, which is the cardinal manifestation, and it is the life-threatening risk of aortic dissection or rupture can happen, leading to shortened life expectancy. Cardiovascular disease is the leading cause of mortality in more than 90% of the cases. These are the diagnostic criteria points for the systemic score used in Marfan syndrome. The wrist and thumb sign is given 3 points. Pectus carinatum deformity is given 2 points. Hind foot deformity is given 2 points. Dural ectasia 2 points. Acetabulate protrusion 2 points. Pneumothorax 2 points. Reduced upper segment bar lower segment ratio and increased arm bar height ratio and no severe scoliosis is given 1 point. Presence of scoliosis or thoracolumbar kyphosis is given 1 point. Reduced elbow extension is given 1 point. And the facial features, out of these 5 features, 3 should be there, which will give 1 point. Dolichocephaly, enophthalmos, down slanted palpebral fissures, malar hypoplasia, and retronathia. Skin stretch marks, if present, is given 1 point, and myopia more than 3D is given 1 point. Mitral valve prolapse is also given 1 point. Coming to the Gent criteria for the Marfan syndrome. In Marfan syndrome, the presence of family history of Marfan syndrome is given much importance in diagnosing Marfan syndrome. In the absence of family history, the AO means the aortic diameter at the sinus of Valsalva, where the Z score is more than 2. So the diameter of the aortic diameter at the sinus of Valsalva is given much importance in the absence of family history. The first we'll come to the absence of family history. The aortic diameter more than 2 and the presence of ectopia lentis is Marfan syndrome. The first point. The second point, aortic diameter more than 2 and presence of fibrillin 1 gene mutation is Marfan syndrome. Third, in the absence of family history, aortic diameter of the Valsalva more than 2 and systemic score, which we saw in the previous slide, more than 7 points will be diagnostic for Marfan syndrome. Other than the diameter, presence of ectopia lentis and fibrillin 1 mutation with known aortic enlargement is also Marfan syndrome. In the next 5, 6, and 7 points are in the presence of family history. If family members having Marfan syndrome and the patient is having ectopia lentis and is a diagnostic of Marfan syndrome. With systemic score more than 7 points and family history is Marfan syndrome, and aortic diameter more than 2 with the family history of Marfan syndrome can be given diagnostic for Marfan syndrome. Coming to the differential diagnosis of Marfan syndrome, there are 3 differential diagnoses. The mass phenotype, presence of mitral valve prolapse, aortic root dilatation, and S for striae and S for skeletal changes. This mass phenotype is closely resembling the Marfan syndrome, which is a first differential diagnosis. The second one is the Sprinson-Goldberg syndrome. This syndrome is also characterized by craniosynostosis, the anterior chest wall deformity, the long fingers, and aortic root dilatation. This syndrome is also the differential diagnosis for Marfan syndrome. Patients with homocystinuria, they also will have a tall stature, long bone overgrowth, and ectopia lentis. But the differentiating point is there will be no aortic enlargement, and plasma homocysteine levels are also markedly elevated in this homocystinuria patients. Thus, we can easily distinguish it from Marfan syndrome. Prevention of Marfan syndrome. Certain exertions should be avoided, like sprinting, weightlifting, basketball, and soccer should be generally avoided. These are the burst exertions which will precipitate. What are favored are recreational sports like jogging, biking, and even swimming is also allowed. Coming to the medical treatment, beta blockers, propranolol and losartan, 2 mg per kg. This angiotensin 2 receptor blocker therapy is also associated with reduced risk of type B dissection. Surgical treatment, a threshold for surgical repair of aortic root is 5 cm in patients with Marfan syndrome. For aortic arch and descending thoracic or thoracoabdominal aneurysms, generally the standard criteria of repair is a threshold of 5.5 to 6 centimeters, which is followed in here also. In general, the endovascular stent graft should not be used in thoracic or abdominal aorta or in patients with connective tissue disorders. The incidence is 44% of patients who underwent endovascular stent grafts, many of which are converted to conventional surgical repair at a later period. Coming to the Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is a group of disorders which is characterized by joint hypermobility, skin is hyperextensible, and tissue fragility. The fragility affecting skin, ligaments, joints, blood vessels, as well as the internal organs. All are fragile in these patients. The vascular type Ehlers-Danlos syndrome type 4 is characterized by defective type 3 procollagen, which is encoded by COL3A1 gene, which leads to extreme vascular fragility. The prevalence is 1 in 50,000 to 1 in 90,000, and it is an autosomal dominant condition. These are the types of Ehlers-Danlos syndrome. There are 8 described types. The first one is the Graves Ehlers-Danlos syndrome 1, which has the classical features, and the mites means mild expression of these classical features. Hypermobile Ehlers-Danlos syndrome is type 3. There will be marked joint laxity in these patients. Type 4 is the vascular type of Ehlers-Danlos syndrome, presenting with life-threatening vascular hemorrhages. 5 is X-linked vascular syndrome, Ehlers-Danlos syndrome. And 6, the ocular features are more manifested in the type 6 Ehlers-Danlos syndrome. And arthrochalasis type 7, this condition will present with multiple dislocations in patients with type 7 syndrome. And type 8 will present with classical dental problems. Periodontal Ehlers-Danlos syndrome is the type 8. The clinical features of Ehlers-Danlos syndrome, here also there is a criteria. The major criteria, or the two things are coming under major criteria. Marked skin hyperextensibility and scarring. The skin changes will come under major criteria 1, and joint hypermobility will come under major criteria 2. For diagnosis of Marfan syndrome, either both the major criteria has to be there, or one major criteria with any 3 of the 9 minor criteria should be present for confirming diagnosis. The minor criteria include the easy bruisability of the skin, soft and velvety skin, fragile skin, presence of pseudotumors, subcutaneous spheroids under skin, hernia, epicanthic folds, and presence of joint hypermobility symptoms like sprains, pain, recurrent dislocation, and presence of a first degree relative who fulfills the clinical criteria will also come under the one of the minor criteria. Differential diagnosis for Ehlers-Danlos syndrome. Here the disorders of bruisability will be one of the differential diagnosis, which include the von Willebrand disease, platelet disorders, scurvy, etc. The bruisability is often elicited in battered children also. They may also mimic Ehlers-Danlos syndrome. Other differential diagnosis include the polycystic kidney disease and several hereditary forms of cerebral cavernous malformations, in which also multiple aneurysms of visceral vessels are noted. Coming to the complications of Ehlers-Danlos syndrome, true aneurysms are rare and occurred in only 14% of cases. They present with bleeding in the peritoneal cavity. Patients with Ehlers-Danlos syndrome 4 are at the highest risk of inoperable tissue fragility. The patients will be inoperable. Gastrointestinal perforations also account for 25% of the Ehlers-Danlos syndrome patients. In female, uterine rupture can also occur. Coming to the medical management, celiprolol therapy has been introduced, and the incidence of rupture reduction is 20%. Lifestyle modifications, as the same as Marfan syndrome, lifestyle modifications for Ehlers-Danlos syndrome should be followed, avoiding the burst exertions and following the procreative activities like swimming and jogging. Factor 7 transfusion may be an acceptable treatment. Surgical exploration should be deferred unless compartment syndrome develops due to extreme inoperable fragility. Well, if in case proceeding for surgical management, it is a formidable challenge. Liberal use of adjunctive techniques should be done to reduce the operative trauma, even in both in open as well as endovascular setting. Padded surgical clamps should be used whenever possible, and the permissive hypotension should be maintained between 70-80 systolic pressure during vascular clamping and during suture line testing. Endovascular approaches are also useful in certain cases, like coil embolization of aortic branch vessels and in spontaneous splenic hemorrhage, hepatic arterial tears, etc. It is generally agreed that stent graft therapy for other connective tissue disorders and Ehlers-Danlos syndrome should be avoided. Coming to the next syndrome, this is a newly described aortic syndrome, Lowy-Dietz syndrome, which is characterized by aortic aneurysm and vascular tortuosity. The characteristic feature is craniofacial abnormality presenting with a bifid uvula or a cleft palate. Hypertelorism will be there. The genetic genes which are involved are transforming growth factor beta 1, beta receptor 1 and transforming growth factor beta receptor 2 genes, SMAD3 genes, and receptors. In the LDS type 1, the mean age of death was 22 years in compared to LDS type 2, which is 32 years. Type 3 and type 4 of Lowy-Dietz syndrome may have a later onset of disease. These are the 4 types of Lowy-Dietz syndrome. In type 1 syndrome, here there is predominant craniofacial features. The craniofacial features involve hypertelorism, bifid uvula, and cleft palate. Type 2 Lowy-Dietz syndrome is cutaneous features. Cutaneous features means easy bruisability of the skin, velvety translucent skin, and these are the skin features present in type 2 Lowy-Dietz syndrome. These two types are transforming growth factor beta receptors 1 and 2 mutations. Type 3 Lowy-Dietz syndrome is SMAD3 gene mutation. Here aneurysm with osteoarthritis, predominant abdominal aneurysm and intracranial aneurysm can also occur. Widespread osteoarthritis with cartilage degeneration will be seen in these patients in late onset, more than 40 years of age. Type 4 presents as a morphin-like features, transforming growth factor beta 2 mutation. Similar craniofacial dysmorphism and aortic aneurysmal syndromes will be seen in these patients. This is the characteristic feature of Lowy-Dietz syndrome. The classical triad will be the craniofacial abnormality like bifid uvula and cleft palate will be seen in 90% of patients. The hypertelorism, wide set eyes will be seen in 90% patients, and the arterial aneurysm will be seen in 98% of patients. The clinical manifestations, the cardiovascular involvement is the hallmark of the Lowy-Dietz syndrome. The aneurysms can occur anywhere in the vascular tree now. They are not limited to the aortic root. The arterial tortuosity, particularly the supra-aortic vessels, this is a prompt consideration, especially for the type LDS 3 and 4. This is the picture of a typical LDS child. Craniosynostosis, malar hypoplasia, and the patient will be having blue sclera. In compared to the Marfan syndrome, ectopia lentis was not recorded in any patient with Lowy-Dietz syndrome. The percentage of vascular involvement in Lowy-Dietz syndrome from top to bottom, carotid 35%, subclavian 35%. The vertebrals are 14% among the head and neck vessels. SMA aneurysms contribute to 28.6%, iliac aneurysms 21%, and SFA or popliteal aneurysm 14.3%. Treatment of Lowy-Dietz syndrome. The medical management, randomized control trials are testing losartan, which is still inconclusive. The surgery would be recommended when the size is 4 to 5 centimeter, or the growth of aneurysm in periodical evaluation, growth of aneurysm should be more than 0.5 centimeter in 1 year, which is the recommended cutoff level for repair. Recommendations for the repair of peripheral aneurysms will depend upon the patient's age, body size, and history, thus making the surveillance very much and high quality imaging critical for these patients. Coming to the next connective tissue, the familial thoracic aortic aneurysm and dissection. These patients exhibit minimal or no anthropometric evidence, no bony features like Marfan syndrome, Ehlers-Danlos syndrome, or Lowy-Dietz syndrome. They have an impressive history of aorta-related deaths or aortic catastrophe in their antecedents. Up to 20% can have a first-degree relative with the same condition. It is an autosomal dominant disorder. with variable expression. This is the Crawford classification for thoracoabdominal aortic aneurysms. It is inherited in an autosomal dominant manner. The mutations include ACTA2, MYH11, and transforming growth factor beta receptor 1 and 2, and FB1 genes mutation. The patient may be presenting with PDA, cerebral aneurysm, or livedo reticularis. The clinical features include the most thoracic and abdominal aneurysm and dissection occur at a younger age. The mean age is 58.2 versus 65.7 years. In familial TIAD, the thoracic aneurysms are most common, 66%, followed by the abdominal aneurysm, which is 25%, and then the least is the cerebral aneurysm, which is 10%. Most common affected is the in ascending aorta, aneurysm is more common than dissection. Aneurysm is 82% and dissection is 18%. In coming to the descending aorta, equal distribution of aneurysm and dissection, 50% aneurysm and 50% dissection will occur in affected individuals. Treatment is complicated by variable penetrance and variable expressivity of the disorder. Some patients at a very minimal aortic diameter, the aortic catastrophe can occur. The growth rates are comparatively higher in thoracic aortic dissections. On an average, 0.2 the familial thoracic aortic dissections are 0.21 per year growth versus sporadic aneurysms will be growing at a rate of 0.16 centimeter per year. The treatment threshold for sporadic aneurysm should be 6 centimeter, and for thoracic aneurysm, and 5.5 centimeter for abdominal aortic aneurysm. This is a technique used for aortic reconstruction of patients with connective tissue disorders. The 360-degree wrap is used to reduce the kinking of short branches as the retroperitoneum is closed. Thank you.